Hello, everyone, and welcome to another special episode of Arthritis Consumer Experts #CR Arthritis series from the Canadian Rheumatology Association's annual scientific meeting. Today, I'm very happy to be joined by Dr. Nadia Luca, an associate professor at the University of Ottawa, who practices as a pediatric rheumatologist at the Children's Hospital of Eastern Ontario. Dr. Luca, welcome to our show.
Thank you for having me.
Now, for our audience to understand, arthritis is not just a disease of aging, it also affects over 24,000 children and youth across Canada, making it the most common cause of chronic disability in children in Canada. Maybe to start off, Dr. Luca, just set that up for us and tell us just a bit about um, just the disease and how it affects children and some of your experience with it.
Yeah, I'd be happy to do that. So yes, as you point out, it is juvenile idiopathic arthritis is more common than perhaps the general population would be aware. We note that about 1 in 1,000 children are affected by JIA, which is what we would call it for short. And it can affect children, as young as even under the age of 1. And then we would still call it juvenile arthritis up until the age of onset of 16 years. And then a lot of people would wonder, does it turn into adult arthritis, once the patient gets older? And the answer to that is really it's its own entity. And we would always say that that patient has juvenile idiopathic arthritis or JIA, even if they were 40, 50 years old. And the reason for that is that it is unique from adult onset disease in terms of the way it presents, the pattern of joints involved, um, and sort of it's the disease course and outcomes. There are a subtype of adolescents that may get a form of JIA that is more similar to rheumatoid arthritis. But there are also the very young who get forms of JIA that are quite different. So how could this affect, a child? Often it presents with joint pain or swelling. Now, the youngest of children may not even complain of pain. They often manifest that in other ways, like not wanting to walk or, not playing as much as they did before. So there are some subtle clues to that. Um, and often it can affect, say, the knee or ankle joints in these young children. Um, and then the other really key component that distinguishes it from adult onset disease is a couple things. One is we see a lot more involvement of the jaw joint or temporomandibular joint in pediatric patients. And that is important because in a growing child, that can certainly affect the growth of the mandible, the jaw bones, and that could cause a very small or retracted jaw and difficulties with chewing and things like this. Secondly, there's a, a coexisting eye inflammation, which we call uveitis, that tends to be most common in the younger children, especially those with only a few joints affected and those that have a marker called ANA or anti-nuclear antibody. So we're very careful about screening children for eye inflammation because that can cause also trouble down the road and would require its own specific treatment. And I won't go into too much more detail unless you have specific questions, but I will just say that I've been caring for patients with JIA now for about 12 years. I trained in Toronto at Sick Kids Hospital, and then I was working in Calgary at the Alberta Children's Hospital, and now I'm at CHEO for the last 2 years. So we see the full spectrum of different types of JIA and different age groups. And I think we're at a point now where things are really optimistic for this group of patients. And the hope is that it no longer will be, the leading cause of disability in our pediatric patients because of effective treatments that are developed and continue to be developed.
Now, one of the things that ACE has shared information about with our audience is the issue around transitioning from pediatric to adult care for JIA. And we're really excited to hear from you today about the work that you're helping lead in terms of the development of national clinical guidelines for the transition in rheumatology, which is also the title of a poster that you're presenting at the annual scientific meeting. So, to start, maybe tell us a little bit about why these national guidelines, that treatment guidelines that are in development, are so important for young people with JIA.
Yeah, thanks for that. It is really exciting work that has taken a large group of individuals. So I'm co-leading that with Dr. Elizabeth Stringer from Halifax, and as well Julie Harrington, who is an ACPAC physiotherapist in Hamilton. And so this all started after a priority setting exercise that was actually done at a CRA just before COVID. And one of the top priorities identified by this group of both adult and pediatric rheumatologists, as well as patients and other stakeholders, was that there was this identified need for national practice guidelines. Because transition is one of those things that is quite complex. It's a process. It's not a single defined intervention. And so to have some structure and guidance around what the minimum standards would be was felt to be very important, as well as um, having guidelines to use when trying to advocate for resources for this very unique and special population. And so that was really what motivated us to get going on this work. And we thought it was really important for them to be Canadian specific, because certainly there are other guidelines, for example, in Europe, that are published, but are not necessarily entirely applicable to our medical system in our context.
What, maybe you could describe to us what some of these barriers are that young people with arthritis face when they're moving from that pediatric setting to an adult care setting. I'm thinking about, are they experiencing gaps in care or continuity of care, as we call it? The loss of follow-up, differences in treatment approaches. Maybe you can just outline a few of those barriers or challenges to us.
Yes, for sure. So there still exist several barriers to a smooth transition, as we would call it. So one of them you identified would be like potential loss to follow up, right? So that very fragile time between their last pediatric appointment and their first adult healthcare appointment. Um, could lead to disease flares if their follow-up hasn't occurred. They could end up in emergency rooms, things like that. Things that further complicate that is number one, patients might be moving for school or leaving the province that they were originally in. They may be moving out of their, parents' home or caregivers' homes, starting a new job, starting new schools. So there's so many life changes occurring at that time that sometimes that would make the follow-up, making it to that appointment even more challenging. And so one of the focuses is really around a model of care for transition. How do we best facilitate this? And there are many models that exist currently in Canada where there's a strong effort to bridge that gap between the pediatric and adult side by kind of coming together and having what we would call like a combined young adult specific clinic where you have both the pediatric and adult practitioners there at the same time for one or more visits. And that really seems to foster like a better attachment to the adult healthcare side.
And so if we're looking at the guidelines that are in development right now, what are some of the things that you're looking at that can help um, the healthcare team for that person, that the youth making the transition, have that smoother transition? What sort of strategies or tools are included in these treatment guidelines?
Yeah, that's a great question. And Julie, who we're working with, she likes to divide it up into things you can control, things that you may not have as much control over, and what are some like low-hanging fruit big hits that you can focus in on. So I think we have 15 guidelines currently that are being proposed. And one of those is as simple as ensuring that the young adult has some independent visits with their healthcare provider before they transfer to the adult side. That's super important, but may sort of get lost in the shuffle or not be remembered on the pediatric side, but is really, really required for that self-management skill development. So that's one piece. Another tool that can be used and is part one of our guideline recommendations is to assess transition readiness. And that looks at various aspects of self-management, such as being able to refill prescriptions, know about getting blood tests, booking their own appointments, all those types of things that, caregivers tend to do in the pediatric system. But actually, focusing in and coaching our patients to start taking that ownership. And there are many ways to measure this, but one of the tools is the transition Q. Uh, I guess like questionnaire that we can focus in on. Some of the other things on there, we really want to compile the resources into something that is easy and accessible for patients and caregivers. So we're making a point of putting that all on like a free site with a QR code so that it's easy to find all the resources that they would need in one place. And that would all be very relevant to the Canadian healthcare system as well. So those are just some examples of some of the guidelines that are there. Some of the things, are big, more broad, like hopefully to help with some advocacy around funding for resources to help with transition, um, mental health screening because of the very kind of prevalent emergence of mental health conditions in the age range from 16 to 24. So a lot of these things are brought out in the guidelines.
That's really helpful, and I think we want to congratulate you and your team for addressing this unmet need. And we're really, really excited about the work that you're doing. I think what you've identified in terms of what young people with arthritis and their families and caregivers can take away here is that, treatment guidelines are not just for the clinicians and healthcare professionals, it's for the patients and their caregivers as well. So you talk about, helping with self-advocacy or building confidence in managing their own healthcare and in helping manage this transition. So, so important and incredible work that you're doing. So I think on behalf of ACE and certainly our audience, we want to thank you for the work that you're doing. When do you anticipate these guidelines will be published?
Yeah, so to go through the approval process this spring and then uh, final publication, towards the fall, by the time everything gets edited and whatnot. But yes, definitely within the next few months.
That's really, really exciting. And we actually look forward to setting up another interview when you're about to launch. We'd love to talk to you at that point in time.
Oh yeah, that would be wonderful. And also, I just want to thank you for raising this as an important area of interest. And I will also say that we did have multiple patient partners and parents that were involved in this process. So it was super. interesting and helpful for us on the, on the medical side to hear their perspectives
Mhm.
and what's most important to them. And even some of them who've gone through transition and what they learned, would make it better. So that's really at the heart of the guideline development.
Well, thank you for that. And we will have links to information and resources at the end of this interview. And certainly one of our partners in the community who's doing great work in this area is Cassie and Friends, and we'll have links to their website as well. So thank you, Dr. Luca, again for joining us today and sharing uh, news about this exciting work that you're doing. Good luck at the conference.
Thank you.
And thanks to everyone watching or listening. We hope you can join us again for another episode of hashtag CR Arthritis as we share more exciting science from the CRA annual meeting. Bye for now.